We are going to continue our talk on management of the gastrointestinal obstruction. There are two ways of managing the intestinal obstruction, or the two problems which are of intestinal obstruction. The emergency case, which is important how to manage it. Any emergency, you have to start with the ABCs, and you have to examine the, for example, the airway, and interfere if there is any problem with the airway. For example, he's having aspiration pneumonia or failure of of airway. You have to intubate or you have to give oxygen and so. Breathing, if there is any problem with the breathing, for example, is aspirating as vomiting, and there is failure of the respiratory tract, you have to interfere and give oxygen and intubate. The circulation, you have to monitor the circulation, the blood pressure, if it's dropping or there is hypotension, you have to treat that. How to treat the hypotension and the hypovolemia? You have to give IV wide-bore needle on two sides, IV fluids. You have to give 2 liters of normal saline and monitor put the monitor and put the pulse oximeter and take blood for urea and electrolyte and correct your electrolyte. For example, if there is hypokalemia, you have to treat the hypokalemia. If there is metabolic alkalosis, you have to treat that metabolic alkalosis by giving fluids. The fluids itself can correct the metabolic alkalosis, or you can give the correct treatment for the metabolic alkalosis. But if you correct the fluid loss and the electrolyte, the metabolic alkalosis is going to be corrected. You have to do to lessen the pressure in the bowel by doing a nasogastric suction, and put also a rectal tube and a urethral catheter to monitor the urinary output. And then after this and the emergency situation is controlled and the patient is becoming stable, you can do your other investigation to localize the site of obstruction and to identify the causative agent. Plain X-ray will show you the site of obstruction. Either the dilated loop is large bowel, and that means the large bowel is obstructed, or the dilated loop is within the small bowel only. And as we have said, you can differentiate from the X-ray, you can differentiate between large bowel and small bowel and the cecum, because the diameter is different in what we have said, the rule of 3, 6, and 9 centimeters. You have to be very clear about the indication for intervention. You have not to interfere in any patient, on all patients with intestinal obstruction. You have to correct the fluid and electrolyte, and the patient, when settled down, you can investigate to locate the site of obstruction and to identify the causative agent. Indication for surgical intervention, like presence of strangulation. This will make to interfere in an emergency way, or presence of a closed loop which is not relieved, the distension is not relieved even by the conservative management, and you have to interfere surgically. Surgical intervention could be through an exploratory laparotomy when the causative agent and the place of the obstruction is not known, or when there is a clear indication for surgery, you have to interfere and to do the laparotomy. Certain problems like the volvulus of the colon can be done laparoscopically, or if a tumor, it can be done laparoscopically, or if you want to do a colostomy, you can do it percutaneous and to relieve the obstruction, and later on do the definitive procedures. These are the two important things: the emergency management of intestinal obstruction, which should be very well known, and the elective management of intestinal obstruction. And this will complete our lecture to this time, that we have gone over the definition, the classification, the type of obstruction, and we gave some of the causes of the intestinal obstruction. We divide it into mechanical and non-mechanical, dynamic and adynamic. And we have seen how this intestinal obstruction is important because it carries a high mortality and morbidity. The congenital type of intestinal obstruction, which is at birth, or what we call pyloric stenosis, it will present at 3 weeks. Intussusception also in pediatrics is 6 to 9 months. Mecal diverticulum also will be present in pediatrics. Also these things which are occurring in adult, like a hernia, for example, it can occur in pediatrics also. Inflammatory bowel disease like Crohn's, and it occurs in adult. And old age, usually the obstruction is caused by either functional colonic failure, what we call Ogilvie syndrome, or is caused by tumors, benign or malignant, mostly malignant in old age. In the pathophysiology, we talked about the disturbances in the peristalsis and the disturbance in fluid and electrolyte. Also, electrolyte can cause some sort of paralytic ulcers, for example, hypokalemia. There is going to be some scenarios so that we can solve them, and some questions about intestinal obstruction. Thank you very much for listening. Thank you. The lecture outline of the intestinal obstruction. We are going to